Hi y'all, I wanted to talk to y'all about chest tubes, particularly ones that are used for drainage. So in this case, I'm here with Bubba. Bubba has a chest tube in with him. And this one in particular, I'm going to show you the chest tube itself, and then the actual drainage system is down here at my feet. And I wanted to show you how it actually worked at the bedside. And so for this case, this drainage system would be used to remove air, to remove fluid, blood, things like that, to relieve a pneumothorax, those type of things. And that's why we would have this in place. Now these type of things, these chest tubes, they can be placed in the OR, they can be placed bedside, emergency, after surgery, all different types of cases. Okay, so, you know, in Bubba's case, we're gonna say that it was for an infection. So we're draining off, you know, pleural fluid. He doesn't have any in there, but that's what we're gonna say for his case, that we're draining off fluid from his pleural cavity. Okay, so the chest tube itself is not the actual thing sitting on the floor, that's the actual drainage system. This one is called a pleurovac. But the chest tube itself is this part, the part that's actually sticking inside of him. Well, it's not in him, but it would be in your patient. And it's stitched in there so that it stays in. The tube itself is stitched, the skin around it is stitched closed. And on the ends of this, you can see that there's nice little holes in there. And that's so all the fluid, air, blood, whatever it is that we're trying to get out can come out. And it drains down to this tube into the drainage system. Now I'm going to show you that really up close here in a little while. But this is what it looks like up close. This is what's actually inside the patient. Okay, and of course we want to keep a very close eye on this and make sure this doesn't come out. And we'll talk about what happens if it comes out after a while. So I'm going to put this back where it was. Okay. As I go down the tube here, you can see that I have a clamp here. Well, there's only certain occasions I really want to clamp this. Right now I want to keep it unclamped because I want all this stuff to drain out of Bubba's chest. So we're going to keep it unclamped, and I really want to make sure that this, just like a Foley tube, kind of stays loose and damp. Okay? Just like the Foley bag, I want this drainage system to be lower than my actual patient. Now in this case it's going to be on the floor. A lot of times you would see it taped to the floor so that it doesn't get kicked over. Okay? This one is actually hooked to suction, and I don't know if you can hear it or not, but it's bubbling. So that's what it's supposed to be doing. Again, I'm going to give you a closer look at that in just a second. Okay, so how to assess this thing. So what I'm going to be looking for is literally at his site, there's going to be a dressing there. I want to make sure that's clean, dry, and intact. If I have to change it, there's a technique to it. You can look that up in your book. I've never changed an actual dressing because that was always done by a surgeon or a pulmonologist or something like that. That wasn't something we did because it was a sterile technique, and we did not do sterile technique on the floor. ICU nurses do that, but I did not. So while I can, I didn't. That was something we did in the OR. But I want to make sure that that dressing is clean, dry, and intact. I want to make sure there's no kinks in my hose. Okay, because if there's a kink in the hose, nothing can get out of the chest. Also, if I kink it, if I clamp it, I can cause a tension pneumothorax. Air gets in, causes my lung to collapse. Okay, so then I'm defeating the purpose of actually having the tube in there in the first place. Not something I want to do. Now, we do clamp it in certain cases, but I don't want to clamp it if I'm not supposed to be. Okay? While I go down here, I also want to make sure I don't see any clogs. Like if you can see, because you can see through the tube. It's semi-transparent, but you can see if there's something stuck there. So I want to make sure it's paved. I can see things draining through, and everything's going through. As I go down, I'm going to look into my actual chamber itself, and I'll do an assessment of the actual drainage system. So this one is an actual wet suction. Okay, so it's all water inside there. You can either have it to suction or you can just have it to gravity. I've always seen it to suction because that's the way the patients on my floor ended up. So, and this is the more common one that I would see on a test. what kind of assessment we would do. Now, let's talk about assessing the actual suction or the drainage system itself. So I'm going to move you a little bit closer, and I'm going to pull the drainage system up on the bed where it's not supposed to be, but I'm going to show it to you. Good bird's eye view. All right, well, I'll just hold it up. Okay, so you can see the whole Pleurovac here. Okay, so now as you can tell, it's actually working. I hooked it up so we could see exactly how it works. So you can see in this chamber here. Okay, so this one's supposed to be bubbling. This one's bubbling a little much. Okay, but either way, it's supposed to be bubbling. That's not bad. Where it's bubbling out, it's not bad. It's just because it's not actually hooked into a patient, it's a little vigorous. So on your patient, it might be a little bit slower. That's fine, as long as it's bubbling. As the patient, as the pleural cavity gets less and less full, as we stop needing the actual chest tube itself, this slows down a little bit. Okay, over here I have, you can see the fluid inside of there. This right here tells me about what kind of suction control I have. Okay, and so this part right here will go up and down as the patient breathes in and out. It's supposed to be filled up to this line, but the water I put in here didn't work out. Again, because it's not actually hooked to a chest, it's not where it's supposed to be. But it will go up and down as the patient breathes in and out. It's more dramatic when we first put it in, when they need it more, and it becomes less dramatic and could sometimes disappear as we don't need it. But what I'm looking for is I'm looking for it to go up and down. If it is going up and down, that means this is functioning correctly and my patient's breathing. Now, if it was going up and down and all of a sudden stopped, that's a problem. I want to make sure that there's nothing kinked or a clog in my line somewhere. This part over here, this is where all the fluid would collect. So in Bubba's case, this is all the purulent fluid, infection, serous fluid, or anything that's coming from the actual surgery or infection that he has. So how this works over here, we don't change this. This stays for the entire time he has a chest tube, unless it gets completely full, and then we would have to change it. But as this comes up, I would mark at the end of my shift, or whenever I take my eyes and nose for that, I would mark it on here, put my initials, the date and time, and then I would document that. The next nurse comes, goes above wherever I'm at, puts their mark, wherever the mark, wherever the fluid is at that point, marks it, initial, time, date, and takes the difference between the two marks and documents that for whatever time period, 8 hours, 12 hours, whatever it is that in between your eyes and nose. That's how we document for the input or the output for this. Okay, so that's all of this. Now again, you can see it's all bubbling. This is normal. Okay, if it all of a sudden stops bubbling, again, that's something we want to investigate. That's a problem. But if this is bubbling and this is tidling up and down, that's a normal assessment of my Pleurovac. I'll put this down so I don't have to. Okay, so move you back. Okay, so other things I need to know about this. Okay. If I need to change the actual unit, if it gets full, that's when I would clamp my tube. Okay, that's one of the very rare times I would clamp my tube. Any other time would be sometime like a doctor would order me to do it. They want to see if there's drainage coming up, or they want to measure something. You know what? That's when I would clamp it. But most of the time, it's going to stay unclamped. Especially on like a med-surg floor. Now, ICU floor, that would be a very different story. There could be other times that they'd want to clamp it for other reasons. But on a med-surg floor, which is what we're studying, then, pretty much the only reason I want to clamp it is to change the unit, or if the doctor wants to do some kind of procedure or measurement with it. It's the only time I've ever seen that happen. Again, we want to keep it below the chest because that's the drainage thing, just like a Foley. Marking and measuring it is very important, just like if I was doing ins and outs for any other thing, for Foley, for eating, for anything else. That chest tube is an output, and I want to document it as such. We want to avoid trying to kick it over, which is why commonly you'll see it taped on the floor, so that you don't kick it over, because kicking it over is not a good thing, because the stuff gets all mixed up. It's not a good thing. Now, if I saw something I wasn't expecting in that collection chamber, like for Bubba's case, we are expecting to see serous fluid. We might expect to see some purulent fluid in the beginning if we're treating an infection, but I wouldn't expect to see blood. So if I'm expecting air and I see blood, that would be an issue. If I was expecting to see serous fluid and I all of a sudden see blood or pus that wasn't there before, that would be a problem, and I probably want to contact my provider. Okay, so something I wasn't expecting in the collection chamber is something I want to contact my provider about. So blood is a big deal. Now, if they're draining blood in the first place, so if they had a hemothorax, a hemopneumothorax, okay, if they had blood in the pleural cavity and we were already draining blood, okay, that's an expected. But if it wasn't, if it was a tension pneumothorax and I all of a sudden got blood, that's an unexpected finding. And I'd want to contact my provider to see, to get them down there, number one, because that's definitely not something I wanted to see. And two, to see if they had any additional orders. You have to keep that chamber full. Like I told you, it's supposed to be at 20 and I had some issues with it or whatever. So if it goes below 20, the titling, if it's going down, you want to keep that chamber full. So that is one of our responsibilities, to make sure there's enough water in there. And there's a way to fill it and all that kind of stuff. So when you see it inside the classroom, you'll be able to see that. Obviously, we want to make sure that we assess the patient just like normal with vital signs, lung sounds. So all of a sudden, I have lung sounds at both sides, and then they have this chest tube in, and I lose lung sounds that I had before on the side with the chest tube. That's an issue. I definitely want to investigate that and contact my provider about that. That's an unexpected finding. Let's see, what else? Making sure that I tell you. We want to make sure that all the rest of the interventions are in place. Deep breathing, incentive spirometry. They're not exempt from this just because they have a chest tube. Okay, now of course we don't want any sudden movements. We want them to be aware of the chest tube, but we still want them to do the good respiratory toilet, like I was talking about, to make sure that those lungs are expanding as much as we can. So turn, cough, deep breathe, very important. Incentive spirometry, very important. But this chest tube is definitely another one of those assessment things, another one of those nursing interventions, another thing for you to assess at the bedside. And it's extremely important that you do keep a track of it. If you have any questions, please let me know. And